So let's talk about testosterone. Continue talking about testosterone. We saw a few patients that have history of prostate cancer and was treated. And we know that guidelines and many new research talk about the safety of replacement of testosterone after 1 year of low risk or intermediate risk. We saw some patients with higher degree risk. What, how do you conduct these patients of, it's not on the guidelines, or you have some research, new researches to embase your treatment of high degree or metastatic? I don't know.
Yeah.
How do you deal with?
So I think it's important to remember that guidelines are guidelines
Yeah.
and not laws. And guidelines just mean basically that we must follow the highest level of evidence available. And in areas where we do not have high level evidence, we need to counsel our patients on the limitations of the evidence that we have available, what we know and what we don't know about these various situations. And then through shared decision making with the patient, making sure they understand what are the known risks and what are the potential unknown risks, ultimately leaving that decision up to them. So I think in general, most people would agree that a man who had his prostate removed for cancer at age 40, who is now 70 years old with severely symptomatic hypogonadism, and his PSA has been undetectable for 30 years, that he should be somebody who can safely have testosterone replacement therapy with close monitoring. I think you could probably make that same argument pretty easily, that even in a patient who had radiation, who has been cancer-free for many years, that you could also use testosterone replacement therapy with close monitoring. I also think pretty much everybody would agree that in a patient who has symptomatic metastatic prostate cancer, that patient probably should not receive testosterone because of the risk of progression and progression of the symptoms. There's a lot in between those patients who are cured and those patients who have symptomatic metastasis, where it's not clear what the right or wrong answer is. And this is an area where I find that collaborating very closely with the medical oncologist and having extensive discussions with the patient regarding their goals of care, is their most important priority to optimize their quality of life, their energy level, and their sexual function, or is their most important priority to minimize the risk of cancer recurrence? And I think once you have an idea of that, you can come to an agreement on the patient of, are we going to try testosterone or not? But like I said before, if the only symptom is erectile dysfunction, it's probably not related to their deficient testosterone level. So usually these patients, we're seeing them more for their energy level, hot flashes, libido, etc., and having those kinds of conversations. Now, if through a shared decision-making approach, we decide to try a period of testosterone replacement therapy, I usually like to use a shorter acting type of testosterone. So I usually categorize testosterone replacement therapies into short acting, intermediate acting, and long acting. So long acting, in the US we have pellets, or sometimes you have long acting injections like Nebido. And then intermediate, we have the subcutaneous and intramuscular injections. And then the short acting is going to be, in the US, oral testosterone undecanoate, and also topicals. Okay, so in these patients where they have prostate cancer, especially if we know that they have potentially some active disease, whether they're metastatic and asymptomatic with a stable PSA, or perhaps they had more advanced prostate cancer and had hormone therapy with radiation and their PSA has been acceptable for a period of time. In these patients, I generally prefer using a shorter acting testosterone, so we're really only boosting their levels during the hours of the day when they need it. My personal favorite is the oral testosterones, because they have a relatively short duration of action. You could also, in this short acting space, consider the intranasal testosterone, Natesto. But with the orals, sometimes I'll dose it, even though it's supposed to be twice daily, I'll dose it just once a day. And the patient will take it whether either in the morning or in the afternoon, and then for about 6 to 8 hours afterwards, they'll get the benefits, but they spend the rest of their 24-hour period with their levels lower. So we don't really see much change in the PSA. Some patients might prefer the twice-a-day dosing, but always, when I start a man with prostate cancer on testosterone, I monitor that PSA very closely, and I also monitor their testosterone levels to make sure that we're not getting too high with our peak levels. We do expect after initiation of testosterone for anybody who has a prostate to probably see some slight increase in their PSA. So I usually check that first level if I'm starting an oral testosterone after 1 month. Then I'll monitor closely every 3 months. Even if the PSA jumps up a little bit, as long as it stays stable, I feel comfortable continuing that patient on therapy. If the level's continuing to rise, that may be a reason to have another conversation with the medical oncologist and probably stop the testosterone. And then the last situation I think is worth mentioning is an area that's been written about extensively by my colleague Abraham Morgenthaler in Boston. And this is in men who have advanced metastatic prostate cancer, who after extensive discussion with their physicians have decided to really, they want to focus on quality of life rather than quantity of life. So these patients, even if they have advanced prostate cancer, may choose, rather than living the rest of their life on hormone suppression therapy, to start testosterone, to stop their hormone suppression therapy, and maybe even start testosterone to get their levels in more of an area where they can have that quality of life. And then certainly reconsider, for an asymptomatic patient, if he does develop symptomatic metastasis, then reevaluating. But this is an approach that I think for the right patient who really understands the implications can also be considered after an extensive discussion.
Perfect. This is one of the most motivations that I have to came here, because we always have access to guidelines, and guidelines is not the real life. Guidelines it's made by a board who have concerns about the entire world. Will apply that kind of thing. So that opinion of the specialists and the reference center, it's high the high importance for me.
And one quick comment. The other thing when you are considering these sorts of treatments that require very close monitoring is to consider the patient and make sure that you're choosing the right approach for the right patient. And what I mean is that a patient who is unreliable, who is inconsistent in their follow-up, who may or may not get the follow-up blood work, is probably not the best patient for this. Perfect. You want somebody who's very engaged, who's coming for their follow-ups, who's proactive, who if you for some reason don't see their lab value, that they know what it is and they're going to reach out to you to give advice. So that's another thing, is you always have to consider the individual patient, and you can't have one approach for everybody.
Perfect.